Gary, you'd mentioned the 25-year rule. So presumably, the other question is, are there any other major therapies on the way, apart from dupilumab, that we may see within the next 25 years?
Yeah, so I think what's been really disappointing has been the lack of progress outside of the T2 space. So when that biology was discovered, the field has put a lot of resource into it, and we have now 3 anti-eosinophil drugs that are marketed. There'll be dupilumab and things that follow that, thiamine stromal lymphopoietin, but they're all on the same small subset of severe asthma. It's been much harder to tackle the neutrophil variant form of the disease, so the interleukin-17 interventions and other interventions haven't been successful. They've blocked the neutrophils but not produced a benefit, and that's become a real challenge. So there are a lot of trials underway, but I'm not hopeful that any of those will give us quick breakthroughs in that more difficult subset.
Any questions from the audience? Jason DeCosta?
Oh, Brett, thanks for that excellent summary. I just wanted to ask, do you have any sense of, I mean, it's probably not your domain, but the people who are dying at home with asthma or on the way to hospital, are they in any way different to the people who make it there that you can intervene upon? Are they dying of asthma, or are they dying of one of the systemic complications of the disease, or is there any sense of that in the literature?
Other than the social disadvantage, I mean, I don't know. I suspect the pathology is the same. I just suspect the access to healthcare is worse. I haven't looked further into that. Sorry, someone else may have an answer to that.
Christine, did you want to comment on that?
I just was going to say that we still don't know about the 10 asthmatics who died in Victoria, and that's still under wraps with the health department and the coroner. But I think that will be really instructive. And of course, many of them were named in the paper and what have you. So we know that many of them were had not been taking medications and what have you. So compliance was an issue. But I guess we'll get more information about at least those people in hopefully soon.
Kind of media-wide event to drive this kind of investigation. We're very bad at sort of basic autopsies and things these days, I think, and finding out actually what happens to these individuals. Can I just ask a follow-up question while I've got the mic? You talked about magnesium reducing emergency department discharge. Do you think it's right to be discharging severe asthmatics from the emergency department who have presented with an FEV1 less than 50% or a peak flow less than 50%?
Well, I haven't worked in the ED for some time now. I think that's maybe an answer for a question for the ED physicians. My anecdotal feeling is that the really sick ones don't get discharged because they stay sick. I think there's some overcooling severe asthma. I think there's overuse of magnesium in the ED. I think that study show, even in that placebo-controlled study I showed you, a lot of the inclusion criteria was supposed to be severe asthma, and yet the mean was 54% of predicted. And so I don't know. I think, and also you get mixed in with the anxiety overlay with asthma, and the sensation of breathlessness and all that sort of stuff that comes with these acute asthmatic attacks. I think if the pathology of the acute asthma attack is not responding, they don't get discharged because they don't get better. Does that make sense?
Sorry, I just wanted to draw you out a bit, and maybe from others in the room as well, but you mentioned the low use of peak flows, and you acknowledged that vocal cord dysfunction was often coexistent in these people, and that these patients are often given, this burst therapy, actually I don't know the evidence behind that burst therapy. It is there in the asthma guidance, but I can't see where it's come from, actually, those really, really high doses that we're giving those people. And I'm also concerned about the number of people who have, lactic acidosis and tremor and distress, and that's often then interpreted as worsening of their airflow obstruction. Silent chest might be actually improving, but we don't have any lung function measurements. I'm a bit obsessed about, I can't even get lung function done on my ward, my respiratory ward. The registrars and residents are not particularly interested. Of course, they can go down to the respiratory lab, but that takes a few days. So they come in and they go, they've got presumed COPD or presumed severe asthma. And I go, well, what evidence do you have for that?
Yeah, I can't explain why there's reluctance. A peak flow meter is a little cylinder. It's not hard to stop.
You know how they have these bundles these days. They have COPD bundles. You have to tick off. You mentioned tick this, tick gas is done, usually venous, tick, 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 tick. Why can't we add that in? It's a useful thing if it's done properly.
Again, this is for the emergency department.
Sorry,
My colleagues, I no longer work there, but look, I think it would be a great study. I haven't looked at the literature to see what the rates of using those objective measures are. I think there's a study there, and I think people just go, and look, EDs are getting busier and busier. They've got the 4-hour rule. The practice of emergency medicine is changing. People come in and say, my asthma's playing up. They get shunted to the resus room. They get 5 milligram nebulized salbutamol back to back. They get, in the first hour, they have 3 atropine nebs. They get IV hydrocortisone when usually they can swallow, so why are they getting prednisolone? And then they get toxic, they get on BiPAP, we get them, we have to make a decision what to do. The ED can't have them there for another hour and a half in the resus room because they've got a 4-hour rule. They come to the ICU, we stop the salbutamol, in 2 hours they're having lunch. I mean, this is all anecdotal, but I agree with you.
Actually, I might interrupt there as well, because I think it's an important point. We can actually do a survey here quickly, given we've got a few bit different people. So how many people here, their ED department would routinely measure spirometry in patients with asthma? How many people here, their ED department would ever measure spirometry in patients with asthma? How many people here, their ED department would actually have a spirometer? They have a spirometer, but it's locked away. So I think there are some important points for management. Yeah, that's right. Just one other question. Gary mentioned about endotypes. Now, I guess two other difficult groups are the smoking asthmatic, and that seems to somehow alter airways and things like that. And I was going to ask if there's any new information about potential therapies, given steroids seem to be relatively less effective in that group. And the second group is the obese asthmatic, where there seem to be factors that are driving changes in airway physiology as well as the mechanical effects on the airway. So Gary, are you able to comment on whether there's any potential targets for therapy in those two groups?
So there's been really good progress in that area. I think in the smoking asthmatics, smoking is a clear determinant of asthma severity because it damages the lungs, it does in COPD, but also changes host defense. And I think the frontier area is the altered metagenome, which is really seeming to contribute to driving very severe airflow limitation that's difficult to treat. In fact, steroids probably worsen that whole problem. So I think as we deconvolute the interaction between smoke, colonisation, subclinical infection of the lung, and altered lung function, that will be a really important breakthrough area. Then on the chubby side, something I always pay attention to myself, I always reach down and sort of squeeze my abdomen here. There's just the physical compression of the lungs that Charlie Irving's noted, and that responds to bariatric procedures because it's a compression problem. But there's real biology, and the emerging areas there are leptins, which affect the airway physiology, and then the free fatty acid receptors. And so there's been some really important breakthrough work on free fatty acid receptors that interfere with bronchodilation pathways, and new medicines that are being developed, actually probably useful in very severe asthma because they're complementary to beta-agonists to produce further bronchodilation when beta-agonists have reached their limit. So that's a frontier area, the free fatty acid receptors.
Okay, that might be a good point to finish. So thank you very much for your attention. Thanks for 3 great presentations and morning team.